Good morning, everyone. Hope everyone is doing well. I am going to be talking about mostly the Choosing Wisely campaign today. Has anyone ever heard of it? Some nods, maybe? Yes. Good. I know Dr. Sinnert is here and Dr. D'Souza. I'm sure they've heard of it. Okay, great. So I wanted to have some dialogue today about cost awareness and physician stewardship because, one, it is an important sort of competency we're supposed to graduate with every year, and definitely something that on our ACGMA survey, Dr. Willis can correct me if I'm wrong, but I think it's an area that we feel like we're not getting enough dialogue on, even though we have these conversations on shift and during our admin rotations and in our email chains with our attendings. I think it's something that we can sort of talk about a little bit more. We're not the only program that has this issue. I think in general, physicians are usually not a part of this conversation when it comes to healthcare spending and healthcare expenditure, and also in wasting of resources and inappropriate testing. And even though I'm not the expert on this topic, I wouldn't even pretend to be anywhere close to that. I wanted to share some resources that I think are really accessible to us and are not too difficult to sort of engage with in terms of this dialogue. Okay, so a couple questions for you guys. I'm going to pick on someone. Rabani, do you feel comfortable talking to patients about why they should avoid an unnecessary test or procedure?
Depends on which test or procedure.
Okay, so dive into that a little bit more. Like, which tests are you comfortable saying, I don't think this is necessary, you don't need this test? And which ones do you not feel comfortable talking about?
I really love telling patients they don't need a head CT when they're like 20 and haven't taken any like headache medicines and they think that they are like having a cancer or something. I don't know. I love that conversation because I can like really explain like the radiation and like the risks, benefits and stuff like that. Um, I guess. I guess like the harder ones are like the ones where sometimes it can be like a little more ambivalent, but especially well, the other ones that sometimes are harder, but I still like are very important are like the antibiotics when you're having like a viral syndrome or something. But I think it's the hardest when it's like in peds because like it's easier to like explain to an adult why they don't need it, but like when it comes to like their child, they want more sometimes. So like that's a little bit more of a difficult conversation. But yeah, I'm
Okay.
blanking.
No, that's perfect. That's great. So the Choosing Wisely campaign did a survey that was sort of a cross-sectional survey of about 1,000 practicing physicians and asked them that same question. And only 15% of physicians said they felt um, only somewhat comfortable having these conversations. Only 3% said they were uncomfortable. So I feel like this is sort of not what I expected. I feel like I expected more people to say they were uncomfortable saying no to patients or counseling patients on unavoidable tests. So I think that's something to keep in mind for the rest of this lecture. Dr. Murtaugh Taylor, what do you think about this question? A patient is convinced that he or she needs a specific test, and you know the test is unnecessary, but they are insistent. What do you do?
Again, it kind of depends on the test. Um, Certain things that I think are not harmful that people want, I don't care very much.
Okay.
But things that are going to be harmful to them, I kind of explain the harms. Try to have a conversation with them and try to get to the bottom of why they really want this test. Because a lot of the times, the reasoning for why they want this test like actually doesn't make sense for what the test is actually going to answer. And I think they're just kind of steered in this direction based upon Google or family member or someone outside of the medical community. So usually getting to the bottom of why they want the test sometimes helps.
Okay, perfect. So that same survey of attending physicians across multiple specialties and across the country, the answer to this question is for them that they would either order the test or order it and advise against it. So that's 50% of attendings. And then 40% would just refuse to order it entirely. They don't go into details in like how they would have that conversation and what that would look like. But I think um, it's interesting to sort of see that split in the decisions that we make when it comes to counseling patients that are insistent on a test. And the last one, maybe Dr. Shabawale. What do you think about this question? In your own practice, what are the reasons that you sometimes end up ordering an unnecessary test or procedure?
I think with emergency medicine, there's also an aspect of a patient care centered model, especially as you go into more like private community-based practices. So I would just document, had a conversation with the patient on the risk to benefits alternatives, educated them on this, but sometimes it's not worth a fight, so I'll just do it.
Okay, so your reasoning then is that sometimes it's not worth the fight, is what you're saying, and that you want it to be patient centered where the patient has a choice to sort of choose what test they want.
Exactly.
Okay, perfect. So, again, back to that same survey, some of the top reasons why physicians order unnecessary tests and procedures. 50% of the time, it's for malpractice concerns. 36% of the time, it's just to be safe. 30% of the time, it's just to reassure themselves a little bit more. 28% of the time, it's because patients insist on the test. 20% of the time, they want to keep patients happy. And then there's a sprinkling of some other reasons, such as the one you said, feeling that patients should make their own decision. And then not enough time with patients, which I think is kind of a crappy reason. And fee for service systems, which hopefully we don't work in, but is a potential option for future jobs. Okay, perfect. So that sort of brings us to the choosing wisely campaign, which is where I took a couple of those questions from, and what it's about. And essentially, it was a campaign that was started by the American Board of Internal Medicine in 2012, in collaboration with about 80 other specialties, which includes emergency medicine. And their goals were really to promote conversations between clinicians and patients about tests that are unnecessary, because they're either harmful or of low value. And so together, this organization with all of these specialties have come up with over 700 recommendations. And it's become a widespread campaign that's even expanded into other countries as well. And again, we talked about their goals, but I wanted to dig into some of those. The main one is to prevent harm to patients. And so the harms that we know can come from testing includes false positives, right? And so finding something that is not real and then leading to unwarranted stress or additional testing for conditions that don't exist is a big harm to patients. False reassurance, right? So sometimes getting that CAT scan of the abdomen when someone's having abdominal pain and they really need a colonoscopy or an endoscopy may reassure a patient that they're okay, when in reality, there is a higher quality test that they actually need that they did not receive during your care. Incidental findings. One, we're actually not even really that good at documenting these and letting our patients know about these when we discharge them with these incidental findings. But even if you are letting them know about these findings, sometimes incidental findings can lead to even more unnecessary tests, where you're chasing sort of pathology that's not really there and wouldn't have made any difference in that patient's outcome or health in general. Radiation exposure, we talk about quite a bit. And then overtreatment for potential pathologies, again, that may not actually affect the patient's health. Strain on resources. So we think about the more things that we're testing for and ordering in our department, we sort of see that downstream effect of delayed care for patients that may actually need these evaluations and tests. And then there's a paradoxical mistrust, which I think is sort of interesting, in that when patients are coming to the, for example, emergency department, and they're getting a lot of different tests, and especially if we're not talking to them about what we're finding, and they feel like they're not getting the answers they need, they start to develop a sense of mistrust in the healthcare system, and that we are actually just sort of doing unnecessary testing, increasing their out-of-pocket costs, and giving them fragmented care that's not very efficient. So those are just a few of the harms. There's a lot more that we can sort of talk about, and this could be a whole lecture in and of itself. But patient cost is sort of the last one I threw in there, and we'll sort of talk about that a little bit more. I think we should all have a little bit of healthy skepticism about any organization. And so I sort of did a little bit of digging on the Choosing Wisely campaign just to see if there was anything out there for us to be concerned about. One, from what I could find, I did not see any specifically political sort of motivations behind their campaign. But I think it's important to keep in mind that they are sort of operating in a very politically charged space. And so the healthcare environment is a politically charged space. And so being skeptical of some of the motivations behind why we're reducing costs and testing is super important. Um, they're pretty transparent about their funding. The majority of it comes from the Robert Wood Johnson Foundation, which is a super huge public health philanthropy. They also get some funding from specialty societies like ASAP from emergency medicine when it comes to developing specialty specific lists of recommendations. And importantly, they don't accept funding from pharmaceutical companies or medical device manufacturers. And so I think that was sort of helpful for me to know kind of going into it. And so for the rest of this talk, I sort of want to go over a couple of different things. One, some of the problems that the campaign sort of faced when they first developed their motivations. Two, how that relates to us specifically on Clarkson Avenue. And then three, going through some of the specific sort of choosing wisely emergency medicine specific topics where I think we can have a little bit of discussion and hopefully giving you guys some takeaways to leave this lecture with. Okay, so the first major problem that the campaign sort of encountered was how to approach discussion on healthcare spending. There's sort of two approaches to it. One, you can look at it from patient harm. And so ordering unnecessary tests, doing unnecessary procedures can harm patients. And I think that's the easiest approach from a patient-centered standpoint. I think the other approach is looking at healthcare numbers and sort of considering that with excess ordering of tests that are unnecessary, we're actually overspending and driving up the cost of our expenditure for healthcare in general. And I think in the end, looking at what the campaign chose to do, they chose to basically avoid looking at everything from a spending and waste of money standpoint and focus on a more patient-cared, reducing harm to patients perspective. And I think that's really important for how they're able to sort of encourage us to establish trust with our patients. I also think it's helpful because when you really look at the money, I don't know, for me, my conclusion that I think the money was not as impressive as the harm that we're doing to our patients. And so I wanted to sort of go into some of those numbers with you guys. One of the focus groups that they had, that they did with patients from low socioeconomic backgrounds, and so those were patients that made less than 250% of the federal poverty level. They asked these patients if they believe that their clinicians displayed bias when ordering tests for them, and these patients said yes. And the bias that they were worried about was not racial or ethnicity-based bias, but actually socioeconomic bias. And so patients felt that physicians were potentially withholding tests or trying to talk them out of tests because of their lack of insurance or their lack of ability to pay. On the other hand, I thought it was interesting that in a survey of actual physicians and whether they consider costs when ordering tests, even though about 49% of physicians say that they do consider costs when ordering tests in their general practice, only 4% of them actually knew what the cost of the tests were that they were ordering. And so it didn't really kind of make sense to me that that we're considering costs and we're telling patients that tests are costly, but we don't actually know what it costs to order any of the tests that we're ordering. And so moving from that point, I wanted to look at like what we actually spend on our healthcare. And I'm going to give you guys a bunch of resources for where I found all this information towards the end of the slide, or end of the presentation. But in general, the US spends about $4.9 trillion on healthcare every year. This was taken from last year's data. Which for me, I was like $1 trillion. Like that word doesn't make any sense to me. I have no idea how to conceptualize that. So I think it's easier to think about it in the percentage of our gross domestic product or how much money we spend on all of our goods and values, our goods and services over the last year. And for that, it's about 17.6% of our GDP. And so looking at other countries that are considered high income countries, for example, Australia, Canada, France, Germany, their expenditure is about 10 to 12%. And same thing for countries like the Netherlands, New Zealand, Sweden, Switzerland, the UK. We're looking at about 10 to 12% of their expenditure. So I don't know, who thinks that 17.6% is like significantly crazier than 10 to 12%? I don't know. I wasn't that impressed. I was more impressed, though, with a little bit more information from the same people that are coming up with these numbers. And that is that even though we are spending this much money on our healthcare, only about $750 billion of it is actually considered to be waste. Which means healthcare costs that are avoidable or that are avoidable or unnecessary. And this was sort of an estimate, which is like less than basically 20% of our total healthcare spending. If you break that $750 billion down a little bit more, about $210 billion of it is unnecessary services. $130 billion is inefficient delivery of care. And then the rest of the 750 billion is actually stuff that's sort of out of our control. So that includes things like administrative costs, inflated prices, lawsuits or patients suing us, and then fraud. And so we don't really have any control over those things. This is sort of the number that's left over that we have control over. And so I don't know, to me, looking at $400 billion in the context of $5 trillion, yes, it's a lot of money, but again, I still wasn't super convinced that we are that us cost cutting is going to be the thing that like saves our healthcare system. And it kind of gave me the same vibes as me being told not to drive my car and to like recycle more, but then Taylor Swift like flies all over the country and in her jet and like kills the environment every single day. So anyway, moving on from that, I wanted to find something more valuable for us, something that's more important than cost cutting. And this was the kind of foundation of this talk, which is the Commonwealth Fund's annual publication that discusses the United States as a healthcare system compared to those previous 10 nations that I brought up in the slides on healthcare spending. And so the Commonwealth Fund is a private US-based foundation that conducts independent research on all of these healthcare systems. And they try to come up with basically advice on what the US can do to sort of compete with other countries. And what they found is that the US is like consistently in a class by itself in underperforming when it comes to all of these other countries. And it's not just that we're spending more money on them than them on our healthcare, but that we really just have a terrible system and we're not providing good care. And when they break that down a little bit more, they look at 5 areas to say what our performance is. One of them is access to care, so how affordable and available our care is. One is care process, which looks at like preventative care, things like vaccines and mammograms. Also looks at like patient safety, as well as like adverse events in hospital systems. The next thing is administrative efficiency, which looks at sort of our EMRs, how we document, how we navigate insurance plan systems and government agencies. They also look at equity, which kind of sort of speaks for itself. So are there differences in the health performance for higher and lower income individuals? And then they look at health outcomes, which is a measure of both life expectancy from birth and deaths from specific causes that are considered preventable or treatable with timely and effective healthcare. And so looking at where we sort of fall for those things, we're actually number 2 for care process, which was pretty like shocking to me. But when you dig into that information a little bit more, a lot of it comes from the fact that Medicare and other payers have these vigorous pay for performance policies that reward institutions for reducing patient safety or reducing patient adverse events and for doing some preventative care like flu vaccines and that sort of stuff. For everything else, we're pretty much like struggle bus. We are 9th for administrative efficiency and equity, and we're 10th for access to care and health outcomes. And so with all the money that we're spending, whether you think it's significantly more or not compared to other countries, we're really just not doing well in providing care for our patients. And that's sort of what I want us to take away from the data here. So big takeaway is even though I think we can sort of move away from this dialogue of reducing healthcare costs, because I don't know that I'm convinced that the overspending is a huge portion of our costs, we really should continue that dialogue of improving patient care, and that includes things like reducing these unnecessary tests. And I think that's where Choosing Wisely campaign chose to not discuss healthcare costs, because I think it takes a lot of the politics out of it as well. So bringing that to Clarkson Avenue, I wanted to sort of see where we fell on that spectrum, because we know that to me, I always feel like a lot of our patients believe that more workup is better. And when the Choosing Wisely campaign did focus groups and cross-sectional surveys of patients from low socioeconomic backgrounds specifically, they actually did find that that was a true thought process, that initially a lot of patients believe that the more things that they get done for them, the better their care is. But what they actually found too was that if there was a dialogue and conversation with these patients, they could do a pre and post survey, and there was actually a lot of thought processes that were changed to be convinced that there's actually not necessarily better care going on when you do more of a workup for the patient. And so there's hope for us to actually have these conversations with our patients and make a difference in how they think about it. I think another question I had thinking about Clarkson Avenue was, okay, our patients are super vulnerable, right? So like my gut reaction is that our patients actually have limited access to care and worse morbidity and mortality than other patient populations where they have higher income. So are they really at risk of any harm if we are over testing in the emergency department? And I think there's a lot of good evidence out there that the answer to this is yes, that they actually are still at risk of harm from over testing. And there's a growing body of research that's showing that the testing, imaging, and procedure overuse is actually spreading into Medicaid and uninsured patient populations. And so we have to sort of think about that in the context of our own patients. This guy, Dr. William Shapiro, is a professor at Cornell. And he did a study where he analyzed the prevalence of low value healthcare services among Medicare patients. And he focused on racial and ethnic disparities in this study. He considered a low value healthcare service to be an intervention that provides minimal clinical benefit and can potentially cause harm. And what he actually found is that, especially when you look at Black and Hispanic Medicare patients, they often received a very disproportionately high amount of low value services and a pretty low amount of high value services compared to their white counterparts. And so he drew the conclusion that there is a double jeopardy for minority patients who were long understood to be at risk of receiving less effective care. They're actually also at risk of receiving more ineffective care. And some of the things he looked at were things like cancer screening, which is considered high value. Our patients are getting less of that. Diabetes monitoring, so A1C checks, that sort of thing, they're getting less of those things, even though they're considered high value in terms of patient outcome. Whereas back pain imaging, for example, like CT scans in the emergency department for low risk back pain, our patients get a lot of those things. And then cardiac screenings in patients that, for example, don't have a lot of risk factors or don't present with symptoms that are consistent with, for example, an MI and can lead to harm, patients are receiving a lot of those things. And so again, he made the conclusion that our patients are actually at harm of unnecessary testing because, one, they are using the ED a lot more and they're staying in the hospital a lot more, which means that they are at risk of us basically ordering a ton of tests for them that may not actually be helpful and may be harmful. And they also underutilize primary care services, which basically reduces their ability to get access to higher value testing. Okay, so when we look at care processes then for our patients, even though we're number 2 in the world or when compared to these other high income countries in this area, we're actually struggling with that when it comes to our specific patient population with lower socioeconomic backgrounds. So big takeaway here for me is both the underuse of high value services and the overuse of low value services is contributing to poor health performance in our specific patient population. Okay. So I feel like I've been talking a ton. I want to switch into like a little bit more of a conversation part of the lecture. And that is with sort of introducing some of the topics that the emergency medicine specific Choosing Wisely campaign tackles in their discussions online. And keep in mind that if you search Choosing Wisely in almost any specialty, you can find a lot of literature like this where they sort of give both patient-friendly information on why we avoid certain tests, as well as resources for physicians to use to sort of bolster their knowledge on why we avoid certain tests in the emergency department. And so you can search Choosing Wisely Emergency Medicine, you can search Choosing Wisely Family Practice, Dermatology, and sort of get information about these over-testing that we're doing in the departments. So I wanted to sort of pose the first one here. Let me pick on someone. Dr. Sklar, what do you think about antibiotic use in adults and children with uncomplicated acute otitis media? And have you prescribed antibiotics for a patient that meets this criteria in the last few years?
Yes, I have.
Okay. Any thoughts, feelings on that?
I think that's like standard of care at this point, but I don't know if it's really choosing wisely.
Okay. Any other thoughts? Is it standard of care to treat uncomplicated acute otitis media with antibiotics, like right off the bat?
There's like a
Watch and
few
wait.
different ways of doing it. You can straight up say the majority of these are viral, and you can return if you don't have worsening. There is the watch and wait approach, where you do prescribe antibiotics, tell them to pick it up if they don't have improvement of symptoms in like 2 days, or you can just straight up treat it. I don't really think there is a standard of care per se now, because you can kind of pick one of those three and have a fair discussion with the parents about what they want to do and kind of informing about the risks of antibiotics, including, worsening diarrhea and the fact that you improve their symptoms by maybe like 8 to 12 hours, which is potentially not noticeable. Although I don't have a kid, so I can't really comment that hard on that. But I think it can be a discussion for sure.
Okay, fair. So, looking at the Choosy Wisely campaign, and they were able to sort of get panels of family practice physicians and emergency medicine physicians together to sort of discuss this. So that's PEM and PEDS and family practice, and they actually do recommend a standard of care to wait and watch and wait in these patients that have uncomplicated cases. And you can do this observation with just analgesia for 48 to 72 hours if the patient is healthy, non-toxic appearing, and doesn't have any of those like dangerous features. And so you are supported in waiting for these patients and not prescribing antibiotics right off the bat. And a lot of these patients, like Esteban said, end up doing fine on their own. Any other thoughts on this specific topic? Okay. What about doing ankle and foot x-rays in patients who have a negative exam with Ottawa ankle rules? Let me see. Dr. Aslam, have you done this in the last couple of years?
Yeah, a lot of times. I don't know, it's hard. The parents bring them and they obviously want the x-ray. I feel like it's really hard to say no in a situation where it's not really too harmful and they've
Okay.
waited for a while.
Yeah, that's fair. Anyone else feel differently about that?
I
Like
have some
trying to
thoughts on
potentially
it.
have, oh yeah, go ahead.
Yeah, like for this, I know often you don't have suspicion of fracture, but I also think like thinking after the ER and like what's next for them, often they're going to have to get an X-ray anyway. So realistically, in our population, like just getting the X-ray can help like speed up the inevitable. And you can find things like, I don't know, for older patients like bone spurs or osteoarthritis that help guide them to their management faster. So I know like we're taught in med school not to get x-rays, but I actually do find it useful in a lot of patients.
Okay. So you're basically saying that there are some patients where it could be useful in their follow-up. Are you able to sort of identify who those patients are based on your physical exam and the history?
Often, I guess not so much for like peds, but like older patients who probably have like an element of arthritis, or like bone spurs. Because even if it's not a fracture, like X-rays can be used to distinguish between like osteoarthritis, rheumatoid arthritis, like other like rheumatological processes. So it can be useful in like differentiating where someone should go next for management.
Okay. I think thinking about the Ottawa ankle rules, you're specifically thinking about trauma. And so I guess from that perspective, does that sort of change your thoughts on whether the x-ray is necessary or not? Not looking for things like arthritis or like a non-traumatic ankle.
I mean, like a lot of these people in fast track will come in like, I twisted my knee today and it hurts more than it did before. I twisted my ankle and it hurts more than it did before. Like it's not that clear cut.
Okay,
Yeah.
fair.
One thing I've noticed, and I'll admit I have a problem. I've done this as well. But one thing that I have started doing with some patients when I really don't think it's necessary is I tell them what I'd be looking for on an X-ray. And they're like, "Oh, I don't think it's broken." And it's like, well, that's the only thing I'm going to see on an X-ray right now. And I'm specifically talking about like an acute traumatic injury. And then a lot of times they're like, okay, no problem. So I think one thing to just have that statement with the patient. And a lot of times they're like, yeah, I don't think I broke my ankle.
I do
And you're
the
like,
same thing,
I don't
Jimmy.
think you broke your ankle either.
I do the exact same thing, but I do find that like doing all these extra tests slows down the emergency room as a whole. And I think that if you want the room to move faster, then waiting for blood work, waiting for extra x-rays, all these things just slow you down. And I think the room just moves much better when you don't do all these things. It's much easier just to have a conversation than it is to wait on all these studies to come back. It just slows you down a lot.
Also,
Okay.
the Ottawa ankle rules and the Ottawa new rules have been externally validated in many different settings. They are a very good study. And I think you can quote them in the medical record and you can quote them to the chart that we've studied this in thousands of patients with similar complaints to yours, and the x-rays are almost 100% negative, and we don't learn anything, and you're going to be exposed to radiology, and you're going to sit here for 6 hours for an x-ray you probably don't need.
I don't think many of the patients care about that, though. I think that they just want their x-ray because they want to know that it's not broken, or they just say they just want it because they want it. I think just waiting for all that stuff just kills the room.
I want to like kind of really hone in on that point, in that it takes us more time, our physical time, to have a conversation with a patient than to get the x-ray. But for the overall flow of the room and the patient experience, the amount of that the 5 minutes we spend with the conversation will save the 3 hours it would take to get the x-ray.
Amazing. You guys are like doing all of my like summary points for me. I don't even need to like finish the presentation. Amazing stuff. Okay, good. So I won't belabor this one anymore, but all of the points that we heard here are the same points that the Choosing Wisely campaign puts forth for why we should spend that extra time talking to patients. And I'm going to give a little bit of a wrap up with some of these scenarios at the end of this talk. We're getting there. Okay, what about this one? I feel like hopefully we're not doing this a ton, but Dr. Beck-Esme, have you ordered a CT head in a simple, uncomplicated syncope in the last few years?
I don't think so.
Yeah, good. I feel like in residency, I was only told to do this one time. And then I was like really stressed out because I didn't really understand if I was supposed to do this for every single syncope patient, but you don't have to. Unless they have high risk predictors, then you are supported by the literature in not ordering CT heads in these uncomplicated cases. And of course, you can dive into a lot of the details that would make a CT head indicated, but you guys know what those are already. And then what about antibiotics after INDing a simple abscess? This one I think we're actually pretty good at as well. Dr. Zhao.
Unless they have risk factors, I don't really do it because the treatment for abscess is IND.
Perfect. And I feel like some of these our program is pretty good at because we care a lot about evidence-based medicine. But you'll see when you go out into the world and practice in some other places, it's a real issue trying to convince clinicians to follow some of these supported evidence-based recommendations. And then this one, our favorite, antibiotics for viral pneumonias. Dr. Galliano, what do you think about that?
Oh, I've had so many of these. I think it's kind of, I feel like I'm usually pretty good at talking patients out of antibiotics for viral pneumonia or even for like bronchitis. Because a lot of them have tried antibiotics before from like a PCP or an NP or mid-level provider. And they're like, it didn't work, but I want it again. And I'm like, but it didn't work. So just kind of having a conversation and using their logic towards why they get a Z-Pack or anything like that usually helps. So I would say I'm pretty successful in this one, but for the last one, the antibiotics with IND, I feel like that one's a little hard when you tell them, though, this is an infection that I have to drain, and then you're like, no antibiotics, go home. You're like, what the? It's a little.
Oh, I've never gotten.
Where'd you get your medical license?
Antibiotics for IND, actually.
Say that again, Dr.
I've never gotten a problem with a patient like wanting antibiotics for an IND. But
yeah, that one I don't think happens as often. I think sometimes
maybe you have a
providers
specific
just
experience.
yeah, I think it depends on like sometimes sometimes it's not just the patient asking for it, but that providers sort of just do it without following the evidence. And so I think that's a part of the problem with this one.
For the
And
viral cases, I feel like people just want something. They don't care necessarily. Most people don't really understand what an antibiotic is. So, like, as long as you explain, like, oh, antibiotics are for bacteria, and I don't think you have a bacteria. I think most people just want something to help them feel better or to stop coughing or whatever. And, you know, that the whole cough like spiel is a different thing. But I actually don't get a ton of pushback from patients about antibiotics for viral infections.
Yeah, I feel like for this one, really, it's like if they've been coughing for a while, they're like, I need an X-ray. That is often hard to talk about, but
So
it's pretty easy and fast. So
I'm going
sometimes
to
I
play
use
the devil's advocate here a little bit. So you see this patient and they do have some kind of infiltrates. Maybe they're fluffy, or how do you know for sure it's viral and not bacterial?
well, that's a good
Just
question,
asking.
Dr. G. What do we use as our clinical like tools to decide on bacterial versus viral pneumonia? I think that's a really great.
Yeah, I'm not talking about bronchitis. I'm talking about you actually see some kind of infiltrates or increased markings that are suspicious.
I think if a patient has infiltrates and fever and they meet then they sort of meet my threshold for an acute pneumonia, and I treat those. Anyone else feel differently about that? Like infiltrates on chest X-ray, especially if it's consolidated, for me, like defines what a bacterial pneumonia likely is.
I give them a Z-Pack. I do.
I have a low threshold to give somebody antibiotics who has an infiltrate. But that being said, I think the clinical course is really important. I think if they come in, they've had 2 days of cough, runny nose, and like virally symptoms, that's different than the patient who had 2 days of cough, runny nose, and virally symptoms, was getting better, and then all of a sudden developed cough and rigors, and now has kind of the symptoms of a post-viral bacterial pneumonia.
Yeah, I think we're talking about different things. I think none of the people speaking right now are giving those antibiotics because they think it's going to cure the flu pneumonia.
Right.
They're giving it because they're worried about a concomitant bacterial pneumonia or a superinfection.
Exactly. And so I think with, again, just making sure that in your mind you have a definition of what a bacterial pneumonia looks like, right? And having that separate from what you think a viral pneumonia looks like, so that you're not sort of conflating the two, and that you can explain to the patient why you think one versus the other, and why you're going to treat one with supportive care and one with antibiotics. And it is a clinical diagnosis. You can have a bacterial pneumonia, for example, that doesn't show up on chest X-ray, right? And so if you're really depending on a chest X-ray to make your diagnosis, then you're also probably going to run into some issues there as well. You need that history and you need the physical exam.
I would also include in the discussion Paxlovid and Tamiflu don't work for flu or COVID.
Yes.
The other thing in this discussion, viral versus bacterial, people have looked at various blood tests to decide whether to treat when you have what's definitely a pneumonia on an X-ray. And the feeling is that you can't use those, that you shouldn't make the decision to use antibiotics based on these blood tests, whether it's a CRP or others, at least initially. Your gestalt is this may be bacterial and the patient's somewhat sick. You go ahead and you treat them. That's what most people would advocate.
I think specifically thinking about like a procalcitonin, we sort of use that in the inpatient setting, I think more so than in the emergency department. And from what I understand, it's more about the decision to stop treating as opposed to decision to start treatment for something like a pneumonia. Is that correct?
Yeah, if you look at the recommendations from ITSA, right, and the American Thoracic Society, the latest recommendations are you shouldn't use procalcitonin acutely to make your decision. That should be clinical and radiological. And you're right, down the road, you may decide to stop the antibiotics based on the procalcitonin, but certainly acutely, you shouldn't use the procalcitonin.
Or CRP or Cedrate. None of those biomarkers make any difference, and there shouldn't be an emergency medicine test.
Okay, last one. Dr. Taylor, are you ordering spinal imaging in patients with non-traumatic lower back pain and no red flags? So that's like no cauda equina syndrome, no weight loss, no cancer, no fever, no night sweats, no illicit drug use, young patient, like not someone that's 60 years old, and normal neuro exam.
No, I don't think I would be. I think for these ones, like my red flag is gonna dictate whether I'm thinking like there's actually something there or need for more imaging. And if there's not any kind of traumatic source, then it's kind of more likely to be more of like a MSK. I'd at least try treating with some analgesia and kind of go from there.
I think the other issue we run into here is the kind of imaging we order for lower back pain. So if you have all of these red flags, like should we really be ordering like an x-ray of the lumbar spine in fast track for a patient like this? Yeah, I don't think I've ever ordered an x-ray of the lumbar spine, but I've seen a lot of orders of that.
I mean, when it's traumatic, you do, but
right.
yeah.
I'm
But
talking about, yeah, right.
And non-traumatic, only
Right.
if they like really, 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 really want it, and I can't really persuade them away. And
so you sort of order the x-ray to appease them, but you're not really thinking about like, I'm going to escalate this to an MRI if the x-ray is negative.
Yeah, in general, most of my patients can be persuaded away from this. Every once in a while, I have somebody, for whatever reason, they just really want it. And I'll be like, okay.
The tremendous radiation dose. A plain
Really?
film, a lumbar sacral spine is a tremendous radiation dose, and it's right in their gonads, which is.
I mean, these are older people, so I don't really care about the radiation dose so much. Like, if they're really insistent upon getting it, but it's only like a handful of cases.
But even if they persist,
And the false negative rate is tremendous.
The answer is still no.
Yeah, the false negative rate is tremendous.
I also run into, you find a lot of false positives or incidental findings that you end up having to do another test anyway. So I always say if you don't want to do CT or an MRI, then I don't think an X-ray adds too much. If you think they need the CT MRI, then it can be a good screening test or initial test like a abdominal X-ray if you're going to do the CT anyway, and you're looking for emergent pathology to act on.
Perfect. So we're not going to talk about these in any details because we're running out of time, but a few others that I thought were interesting to think about. X-rays in peds constipation. I think we do that a lot in the pediatric department. I still don't really understand it. Comprehensive viral panel testing in simple URIs, screening labs in psych admissions, X-rays in first-time wheezers. And these are all specific questions that you can look at the Choosing Wisely campaign materials for and sort of do your own deep dive and come up with your own kind of practice pattern for your future practice. So I think kind of getting into the end of this is one thing that's hard for me, I think, is saying no. I'm sort of a people pleaser, and I feel like it's something that we have to practice doing. If you don't practice doing it, then you're never going to feel comfortable having these conversations with patients. And you can kind of see by the questions that we had on the previous slides that a lot of these topics are recurring. And so if you sort of think about what your spiel is for each of these things, it makes it a little bit easier to sort of have this conversation with patients. And maybe you can cut down that perceived length of time it's going to take to counsel your patient, cut it from 15 minutes to 5 minutes if you have a little bit more organized way of saying no. And so some things that I sort of thought about for myself is I always like to think about the shared goals between me and the patient whenever I'm like looking at a new patient. Patients want you to listen to them and they want to know what's wrong with them. They also want to feel better and they want you to be efficient, but they don't want to feel like you're rushing them too much to try to get them out the door. And so I think sometimes we don't address one of these aspects of the patient's care. And these really don't necessarily have anything to do with imaging or a test necessarily. Sometimes the answer can be in a test, but a lot of the times it can be other interventions that will address the goals of the patient. And then our goals don't really look that differently from that. We want the patients to trust what we're saying. And it feels bad when you try to tell a patient, like, I don't think that you need this test, and they like disagree with you, right? We also want answers. Like none of us really want to like go home and say, I don't know what caused that person's back pain, but we're okay with not getting the answer to all of our patients' care. We also want our patients to feel better, I think. Sometimes I'm a little concerned when someone presents a patient and they forget to like throw on the pain medication for their back pain. But ultimately, it's usually because you like just wanted the answer so badly that you forgot about the symptom relief, but I know it's a part of your goal. And we care about efficiency too, right? We want quick dispose, safe dispose. We want to keep our department moving. And so I think these shared goals help lead us towards how we're going to work up our patients. Some of the tips that I sort of came up with is, again, you have to know the evidence. And so that's why I sort of recommend that looking at some of those categories we talked about before, go and do your own reading on them. A lot of them are questions and have practice variation because there's a lot of like conflicting literature on it, but there are some of them that are like pretty well supported. And I think knowing the ones that are very well supported can empower you to feel more confident when you're telling your patient that this really will not change their care. The other thing is, I always say this, but try to establish rapport with your patients. It won't happen for every single patient. Like there's going to be always patients on your shift that come into it angry, demanding whatever they want, and you won't be able to create that bond. But also gauge their health literacy. I think sometimes we sort of assume that a patient won't understand if we talk to them about literature or talk to them about why we're doing a test and why we're not doing a test, and they actually will. I had a really great conversation with a patient in fast track once with chest pain that came in worried about PEs, and we talked about like the PERC criteria and the Wells criteria, and she like really understood it and felt really reassured that her risk of having a PE was extremely low. And after that conversation, we were able to like avoid doing our workup with D dimers and CTs and that sort of thing. And then know how to highlight the harms of over testing. And so we sort of talked about what some of those harms are in the previous slides, but a big takeaway from the first third of my lecture was try not to approach a patient with I don't want to order this test because it's expensive or because it's going to cost a lot for the system, and sort of emphasize that it's because it's going to harm you or it's going to lead to those false positives, the anxiety of finding something that's not actually there, radiation exposure. And if anything, and you're talking about cost, it should be what it costs to the patient, because ultimately we know that even if the system's cost to us is not really something that we can see right away, there are costs to the patients, like driving up their premiums. Not all of our patients are Medicare, Medicaid, or uninsured. Some of our patients also have private insurance. And so thinking about those things can help sort of guide your conversation as well. And this kind of just points to the same thing I just talked about. Highlight that outcome of avoiding harm more so than the cost of whatever care you're providing. Some of my personal tips, I like to find opportunities for these conversations. And so when I have a patient that tests positive for the flu, if I see a window there, I try to have like a friendly conversation about, okay, next year you should get the flu vaccine. I got the flu vaccine. I don't have the flu. And that's a nice opportunity to be able to have a conversation where hopefully it doesn't come off as you sort of being judgmental if you practice how to say it. I made a dot phrase earlier this year on preventative screenings. I think to me, I'm always like, oh, why do I care? I'm an ER doctor. I don't really care if you didn't get your colonoscopy or your mammogram. But I think it's like an easy thing I can add into my like fast track notes where it's like, you're here for toe pain, but like you're 50. Did you consider talking to someone about getting a colonoscopy for cancer prevention? So, I mean, not everyone is going to do this, but I think it's something easy that I was able to just make in a dot phrase and drop it in there. And I have big ones like people that smoke, getting AAA screening, for example, men over a certain age, or screening imaging for cancer, lung cancer, mammograms. I think those are like easy ones where you can kind of dot phrase into the note and remove it and like mention it to your patient on their way out for that high value care rather than the low value care of getting the x-ray of their toe that day. I like ZocDoc because a lot of our patients, at least at downstate, actually have insurance, and sometimes they want to establish care, and it doesn't have to be at downstate or Kings County. And I've sat down with patients and like downloaded the app with them, put in their insurance, and helped them like kind of practice how to find their own primary care doctor where they can establish care. And you can get appointments like in the next week or the next day, as opposed to sometimes waiting for months to get an appointment at Kings County or downstate. And then in my documentation, I try to do this as much as I can, but putting in an ICD-10 code for any social determinants of health that I think affected that patient's care that day is something I learned from one of our social EM lectures earlier this year. I think it might have been Dr. Lee's. And I think it's very, very helpful because it gives us information that we can use in a lot of these studies, like Choosing Wisely, and some of the other ones that I'll kind of put in my references, where you can sort of take this information and hopefully use it to make patient care better in the future, because it gives us a way to track when these social determinants of health actually affect our patients. So whenever I take care of a patient that is a frequent in the ER, and I know that they're there today because they either don't have a home, so they're undomiciled, or there's some other factor, I try to add in those ICD-10 codes as a part of their final sort of diagnosis of the day. And so there's a bunch of them. You can do some for education and literacy, you can do it for unemployment, for physical environment, for housing and economic circumstances, for psychosocial circumstances. And I think adding those things in there when you're trying to pull data from a lot of these EMRs, it allows you to sort of target these patient populations a little bit more directly. Sometimes you accept defeat. I think that's okay. And we sort of talked about that in our discussion today. For x-rays and labs and MRIs, we're all going to have our own threshold for like how much you're going to try to convince a patient, how much effort you're going to put in before you just sort of say, you know what, whatever, I'm going to order it. For many of us, an MRI is probably not something a patient's going to convince you to do emergently in fast track for their knee pain, but maybe an x-ray, like we talked about, is something that you might give a little bit of leeway into. And then lastly, I have my own personal struggles, I think, with this, just like Dr. Willis talked about and some of the other attendings today. One of them is experience. Like, I'm a younger attending, and so I'm still building my threshold of like what I actually think is dangerous and needs a bigger workup versus not. And even with knowing some of the evidence, I still have fears, and those include having anecdotal cases. Like, I had a really bad pediatric case earlier this year that made me really paranoid about being minimalistic in peds. And that will happen to you in your career, where it might change how you practice for a little while or for a long time. And you have to sort of think about that in the context of how you are choosing wisely in your workup. I had a case with Kelsey Sklar recently where she presented a patient to me about a couple days ago that she said was having early satiety and like vague abdominal pain. And I was like, oh, it sounds like this person needs an endoscopy and a colonoscopy. Why don't we just give them that and discharge them? And she was like, no, even though his belly exam is fine, I still feel like we could probably get a CAT scan and like figure out what's going on, or at least screen for some things. And in an academic center, I try to like give people the leeway to sort of make some of these decisions, because I feel like it also allows you to grow and allow you to sort of figure out what your practice thresholds are. And she got the CAT scan, and this guy had like a crazy like right lung, I don't even know what it was, probably a malignancy that was like pushing his stomach and everything out of the way. And we had to admit him for like, basically thoracentesis and a bunch of stuff that really improved his quality of life and helped him get to a diagnosis a lot faster than if I had sent him home for that endoscopy and colonoscopy. And so I'm kind of done. These are sort of my takeaways for today. I think I went into details already on a lot of these things, and I probably went way over time. But thank you everyone for contributing to this conversation. And I hope that we are able to have more talks like this in the future. I'm hoping to sort of incorporate some of these things into our curriculum going forward and have people that are more, that have more experience and more expertise in these topics to actually come in and talk to us about them, so that we can keep the conversation going. Thoughts, feelings, questions? These are my big references. So one, Choosing Wisely. Two, this Mirror Mirror from the Commonwealth Fund. I highly recommend everyone read this. It really gives you a huge sort of overview of the current state of our healthcare system and why we have a lot of the issues that we have compared to other high-income countries. And then Dr. Shapiro from Cornell's research that he's done on our patient population and why they're still at risk of over-testing and harm from low-value services that we provide in the ER, even though we think that we're sometimes doing better for them by ordering more tests in the emergency department. Thank you.